month, but then he may already be sitting on a macrovascular bomb where he's got atherosclerosis already there by the time he's landed with you. So all that story has already started a couple of years back before he was clinically diagnosed as type 2 diabetes and presented to you. The Mr. Fit study, a very famous study in the 1970s, the multiple risk factor intervention trial. Now look at on your left, these are cholesterol values in men, in diabetics versus non-diabetics. The light blue bars show you people without diabetes. The blue bars show you men with cholesterol values who have diabetes. And look at the difference between, they're almost 4 to 5 times higher in people who have diabetes. If you look at the panel on your right below, this shows you the impact of diabetes on cardiovascular mortality. And if you have more than one risk factors, the age-adjusted CVD death rate increases. So if you have 2 risk factors, it goes up. If you've got 3 risk factors, it goes up. And look at the difference between people who have no diabetes, shown in the light blue bar, as compared to those who have diabetes. So diabetes is a multiplier effect. It has a multiplier effect on even CVD mortality. Now these are CAD mortality rates per baseline cholesterol quartiles. And this is a very interesting slide which shows you Asian Indians in this slide are sitting right on the top. CAD mortality. And you can see Japan, people with the same level of cholesterol will have less CAD mortality as compared to Asian Indians. Look at United States and the green triangle there. It's just trying to approach the age, but still Asian Indians are right on the top. Finland still up there, but other countries, look at Mediterranean Europe, the orangish circles there you see are way down for the same level of cholesterol. Their CVD mortality is much less. So Asian Indians, by and large, have a higher risk of CVD mortality. Now, patients with type 2 diabetes are at increased risk of vascular complex. I just told you that, whether it's acute myocardial infarction, whether it's amputation, end-stage renal disease, or you have people with stroke. The light blue bars show you people who don't have diabetes, and the red show you people with diabetes. So the risk is enhanced in all these 4 important vascular complications. Talking about risks for coronary artery disease, I'm sure all of you are aware of the most common causes of acute coronary artery disease, which include diabetes, smoking, hypertension, dyslipidemia. Family history of diabetes, very important. Atherosclerosis leading to atherothrombosis. But there are several other not so commonly heard. Chronic inflammation, which is now supposed to be sitting at the pathogenesis of coronary artery disease, renal disease, calcium scores. And then you've got people who are over 45, male sex, hypercholesterolemia, familial hypercholesterolemia. So all these factors increase your risk for having coronary artery disease. The European Society of Cardiology has very nicely categorized. Now, this is exactly as I do in my clinic, and you should also be following similar things. How do you assess that this patient is at high risk, is at moderate risk, or is at very high risk? Let's start from the bottom of this panel here. You've got young type 1 diabetics. Never imagine that people with type 1 diabetes do not have risk of cardiovascular disease. You can see here people less than 35 years of age. Type 2 diabetics less than 50 years of age. Duration of diabetes less than 10 years. Without any risk factor, other risk factor like hypertension or smoking, still you've got moderate risk of heart disease. So if you've got a type 1 diabetes patient who's got diabetes for 10 years, he's 25, he's got impending risk for heart disease. Similarly, somebody who's just 35 or 40, he has no other risk factor, he's got diabetes for 7 years. I always consider him in the moderate risk. Now let's go to high risk, who's got people with type 2 diabetes more than 10 years. Without target, there's no target organ damage, which means their kidney is fine, their other blood vessels are fine, but they have any other additional risk factor. For example, they have hypertension, or they are smokers, or they have high lipids. So these are people with high risk. And then you've got very high risk people, people with established cardiovascular disease or organ damage, or three or major risk factors. We just enumerated those major risk factors. Or early onset type 1 diabetes of long duration. You've got a child. I have people whom I saw 30 years ago are now 35. So they've got type 1 diabetes. So all of them are at high risk, very high risk of getting cardiovascular. So if somebody got type 1 diabetes, don't believe that he can't get a cardiac disease. He will get a heart disease like a type 2 diabetes, and he is at very high risk. So this is something that you've got to really keep in mind. And there are excellent cardiovascular risk calculators available. And this is from the American Heart Association, American Diabetes Association. Also use the same ASCVD risk calculator. You can just put in these values there and calculate for. But these are intended for patients who've got LDL cholesterol less than 190 and who have no pre-existing atherosclerotic cardiovascular. These are not for people who already have a heart disease. So if you try and prevent cardiovascular disease in people with diabetes, I'm sure all of you will agree that we need to really focus on 4 important things. The first I would always consider is lifestyle intervention. Don't forget to advise your patients to really change their lifestyle, which is called as intensive lifestyle management. And this would include control on diet, control and increased exercise program. And we're just going to talk about that. The second most important thing would be blood pressure lowering. Third is glucose lowering. And the most important of these would be lipid modification. Why I mentioned lifestyle intervention is because this is going to be the cornerstone at some point of time. It's going to help in blood pressure. It's going to help in glucose lowering. And it's also going to help people in modifying their lipids. So lifestyle will be the base on which all these things will really help people. And this is really depicted beautifully in this very old study published in the early 2008, the STENO-2 Diabetes Center. I know this person, Peter Gate, and this study is a very simple study. What he did was, this is a multifactorial intervention. These people had type 2 diabetes, already had microalbuminurea. Microalbuminurea, it denotes that this person had already endothelial damage. Now what they did was they gave these patients multiple drugs. So these drugs included anti-diabetic agents, antihypertensives, statins, and aspirin, and made sure that their patients stopped smoking. The blue bars show you people with intensive therapy. The orange bars show you people with conventional therapy. And there were just about 160 people. Just imagine this study. It's been running for 14 years. They had a follow-up of 13.3 years, just a couple of years back. And so you can see that if you intensively controlled glycated hemoglobin, which you see in the blue bars, you can see your outcomes were better. Triglycerides, diastolic blood pressure, systolic blood pressure. And this is reflected in the panel that you see on your right. Cardiovascular death was decreased significantly. Similarly, cardiovascular events, you can see significant drop in people who had intensive lifestyle, which is shown in the blue line as compared to the orange bars, orange line there, which shows conventional therapy. And similarly, you can see all the events, whether it was patients going for percutaneous intervention, patients going for bypass surgery, or myocardial infarction, all who received intensive multifactorial intervention benefited. And these were patients really who had lived longer. The new ADA algorithm of glucose lowering, which was published in 2020 January, now very clearly shows you that when you choose glucose lowering agents, you've got to really see what is the comorbid condition of the patient. So if your patient is on metformin and you find he's not in control, then the first agents, if he has atherosclerotic cardiovascular disease, you've got to use a GLP-1 or SGLT2 inhibitor. if the patient can't tolerate a GLP-1 or can't afford the SGLT2. And similarly, if you have heart failure or chronic kidney disease, then SGLT2 is the first choice. And if for some reason you don't have a proper EGFR, then you can put your patients on GLP-1. So what I'm trying to show you is that even glucose-lowering medication will now depend on the comorbid conditions that you have. So if you have underlying atherosclerotic cardiovascular disease, you've got to consider these agents independently of the baseline HbA1c or individualized A1c targets. If your patients are on other agents, try and switch them on to these agents for benefiting their overall profile. The focus this evening would be on management of dyslipidemia. So of the 4 things that I mentioned, lifestyle, managing blood pressure, managing glucose, and managing lipids, we will focus this evening on dyslipidemia management, and the focus will be on LDL cholesterol, because all of us know that LDL particles have both a causal and cumulative effect. It reduces the risk of atherosclerotic cardiovascular disease proportionately to the absolute achieved reduction. And I've shown you in that Mr. Fit study there that if you had reduced cholesterol values, you probably have less cardiovascular disease. It is associated with risk, or it is the relationship is causal. And this is depicted in this slide. Reducing LDL cholesterol by approximately 40 milligrams per deciliter reduces cardiovascular risk by almost 20%. What you see are 2 important lines there. You can see a red line there. These are primary prevention trials, so many of them. And then you've got the secondary prevention trials, which all of you have heard about, the heart protection trial and so on. And you can see in all of them, the lower the cholesterol, the lower the risk of coronary artery disease event rate, which is shown on the vertical axis. And these cholesterol values, which you see on the horizontal axis, are depicted in millimoles per liter. If you multiply that by a factor of 38, you get the answer in milligrams per deciliter, which all of you are used to. So in both prevention, primary and secondary prevention trials, you can see that it benefited once you decreased cholesterol values. So LDL is the primary goal, and statin is the mainstay of therapy. And this has been now almost authenticated by almost all emerging data. And the saying is, the lower the LDL cholesterol, the better, regardless of where your LDL is to begin. So, some people say you don't even have to measure LDL cholesterol. You've got to see his risk and get the value down. So even if your patient had a LDL cholesterol of 100, don't be satisfied. If he falls in the very high risk category, I'd like to keep his LDL between 50 and 70, or even less than 55 in people who are at extreme degree of high risk cardiovascular disease. And this is shown on the right side in the cholesterol treatment trialist program in 2010, which was a meta-analysis of almost 169,000 patients randomized to statin therapy of 2 years or more. And you can see for every 39 milligram reduction in cholesterol values, there was a 20% reduction in major vascular events. And there is a proportionate reduction in CV events with greater LDL cholesterol reduction. So you can see as the cholesterol is dipping down for every 39 milligrams, you're reducing risk. So in your patients, if you're able to reduce his cholesterol values by 39, be sure you've almost reduced his cardiovascular risk or risk of any other major cardiovascular event like a stroke or any other event like that by almost 20%. Statins lower the risk of morbidity and mortality. And these are benefits of statins on major vascular events. So whether it's a non-fatal MI or a CVD death or any other major coronary event, or a bypass or a PTCA or an incidental stroke or hemorrhagic stroke, only except for hemorrhagic stroke, where it is probably believed that statins may increase. But nobody would probably use in hemorrhagic stroke any of these drugs, But all other vascular events, you'll see, all of them are favored by a better lowering of LDL cholesterol with statins. And the Kaplan-Meier curve here shows you estimates of cumulative coronary heart disease free survival. So you've got the blue people on statin treatment, and they were free of cardiovascular events, and the p-value as compared to people who did not receive statins was almost p was 0.001 for difference. And look at the difference there. People who were on statin therapy and people who did not receive statin therapy, there was a marked difference. Now let's see the effect of statins on lipids. Now statins, some people believe that it just reduces your LDL cholesterol. Yes, it does. A high intensity statin dose, we're just going to talk about what is high intensity and moderate intensity. They reduce LDL by more than 50%. A moderate dose would reduce between 30 and 50%. But statins also reduce triglycerides by almost 10 to 20%. And some statins may also increase HDL value. So they have an effect not only on LDL but also on triglyceride and HDL, contrary to the popular belief that they only reduce cholesterol. Now here is a bank manager whom I saw a couple of years back. He's got type 2 diabetes, hypertension, and obesity. He's 89 kg weight, he's got a body mass index, he's got abdominal adiposity, he's poorly controlled, and look at his LDL value is 169. He smokes 15 cigarettes a day. His father had type 2 diabetes and died of CAD at age 69. So my focus here, of course, is on lipids today, but because of some technical issues, we can't show you the animation. So what I've just done is to show you the correct answer, and this probably would come in your mind. So what will be your primary target of therapy to reduce his lipids? In addition to giving him advice on lifestyle intervention. Well, the correct answer here would be LDL cholesterol. What is the LDL goal you would set for him? Well, I would set it either at less than 55 or less than 70, because he's got a family history which is bad. He's a smoker. He's already nearing 40. He's got abdominal adiposity, and he's got an LDL cholesterol which is high. So, he's in a high to very high risk category, and I would probably put him at least under 70. You would initiate therapy with, well, some people would say, very, very popular in India, they will start putting people on statin and fibrates. Well, that's absolutely wrong. That concept is outdated, and, the combinations are playing havoc with people. Fibrates can cause over long-term gallstones. So fibrates have to be used very carefully. Statins and fibrates are not great combination. They can injure your muscle. They can cause rhabdomyolysis. They can cause myositis. So fibrates have to be used very selectively. And in these patients, and this patient also, the correct answer would be TLC. That's lifestyle intervention, total lifestyle changes plus high-dose statin. And there is the answer of how you manage dyslipidemia, and again from the European Society of Cardiology. So in patients with type 2 diabetes at moderate risk, well, less than 100. In patients at high risk, less than 70. People at very high risk, less than 55. In patients with type 2 diabetes, a secondary goal is a non-HDL-C, target of less than 85 or less than 100. That's almost about 30 over the LDL value that you would probably aim for your patients. So these are very important things to understand, but it's also very important to understand that your patients may sometimes not come for follow-up for months or maybe a year. So if you put him on a small dose of statin and he has an event, I don't think the patient needs to be blamed. I think we need to be blamed. So we've got to always think ahead and try him and put him on the right statin dose. Never feel scared in using the right statin dose. People sometimes prescribe 5 milligram, 10 milligram. A 10 milligram is homeopathic dose in people with type 2 diabetes, especially when you're considering people who already have moderate risk, even without risk factors when you have type 2 diabetes. Why do Indians have a justification for a lower LDL cholesterol? And these are These are things which have been worked out by several agencies. This is something from the Lipid Association of India. We developed heart disease 10 years earlier. Approximately 25% of those dying with CAD are less than 40, is more severe and have higher mortality. We've got normal or mildly raised LDL-C, but still have so much of mortality. Got low HDL-C. Then the mean LDL-C of 106 in American population versus 94 in Indians. Look at that difference. And I showed you that chart there. Even with a lower cholesterol value, you are almost at the same risk of higher cholesterol value either in a European or in a US patient. South Asian ethnicity is a risk enhancer, and lowering LDL-C to less than 30 leads to further reduction of cardiac events, which is shown by the 4-year trial. I'm just going to talk to you about that. So it is now pretty certain that Asian Indians have heightened risk of heart disease. And so it's important to have their LDL cholesterols much better controlled than you would probably do for other ethnicities. And this is the Lipid Association of India recommendation 2020. Now this is diabetes. I've specially picked the people for diabetes. This is diabetes plus atherosclerotic cardiovascular disease. Now look at on the left panel, associated comorbidities. Diabetes without target organ damage. Less than 2 major risk factors. The patient is already labeled by the Lipid Association of India as extreme risk, and the goal should be less than 50, optional less than 30. Look at how people are trying to treat now LDL cholesterol. He's just got less than 2 risk factors. He's got no organ damage. Now you've got diabetes plus polyvascular disease. He's already got a stroke. He's already got a percutaneous intervention. Maybe he's got a bypass surgery. He's got 2 or 3 additional risk factors. Maybe he's got a target organ damage. Try and get his LDL cholesterol less than 30. Then on your right is diabetes, but no atherosclerotic cardiovascular disease. He's got no target organ damage. And this is probably the patient I was showing you just now. With less than 1 ASCVD risk factor, and the goal is less than 70. He's already at high risk. With target organ damage or 2 risk factors. Now that patient that I showed you had hypertension. He was a smoker. So he already had 2 risk factors, and that's why I said I would try and get his LDL less than 50. So this is lipid management lowering, again from the European Society of Cardiology, and this is grade A level recommendations. Statins are recommended as the first choice lipid lowering treatment in patients with diabetes and high LDL-C. So no other reagent except statin. If the target LDL-C is not reached, combine it with ezetimibe. That's the only agent that you need to combine it, even when your patients are on moderate or high dose statin. So if I find my patient is already on 40 milligram of Rosuvastatin and his LDL-C is still 70 and I want it less than 50, I use a 10 milligram ezetimibe. In patients at very high risk with persistent high LDL-Cs, despite maximally tolerated statins or in combination with ezetimibe, then you've got these new agents which are injectable agents called PCSK9 inhibitors, and we are going to talk about that in the latter part of my talk. So let's see what are the ADA recommendations for management of dyslipidemia. Of course, as I mentioned, lifestyle sits there on the top. You've got to really advise people to curtail their salt, have a Mediterranean type of diet, decrease their saturated fats, get your trans fats to 0, increase omega-3 fatty acids, viscous fiber, and physical activity should be improved to almost 150 minutes per week in intensive lifestyle, ILS, and of course you need to control glucose, glycemia, to get the elevated triglycerides down and increase the SDL cholesterol. So lifestyle management stays extremely important. Lipid management, ongoing therapy and monitoring with lipid panel. Obtain a lipid profile at the initiation of statin dose. So you can follow it up at about 12 weeks to see how your patients responded to a particular dose of statin. Now let's talk about primary prevention. which means people have no existing heart disease. Now just sit back and think for yourself, do you prescribe statin in the right dose for these patients? Now let's imagine, let's talk about the second line there. For patients with diabetes between 20 and 39, with additional cardiovascular risk factor, he's a smoker, it may be reasonable to initiate him on statin therapy in addition to lifestyle. Don't think he's under 40, so he doesn't need a statin. I think all diabetics need a statin. In patients with diabetes at high risk, especially those with multiple risk factors, 50 to 70, he has to have high dose statin. Let's go to the top there. People between 40 and 75 without heart disease, but he will need moderate statin dose in addition to lifestyle management. And if you can imagine that your patients with diabetes have a 10-year risk of 20% or higher, it is reasonable to add ezetimibe to maximally tolerated statin dose to reduce LDL cholesterols by more than 50% or more. So I would say that all people with diabetes need to be on statins. And we showed you in that chart from the European Society of Cardiology where it said that they are already at moderate risk even when they've got type 1 diabetes or they've got type 2 diabetes less than 10 years even without risk factor. So diabetes itself increases your risk so much that all these patients have to be on statins, and I would say moderate statins even if they don't have a heart disease or significant risk factor. But suppose he has a kidney disease, he has to be on high dose statin. That's a major risk factor. Secondary prevention. Your people already have heart disease, so no question, it's all high statin dose. For patients with diabetes and ASCVD considered at very high risk. Now these will require your LDL to be pushed below 50 or 70, and you've got to add additional lowering therapies like ezetimibe or PCSK9 inhibitors. Who do not tolerate intensity, use the maximally tolerated dose. Over 75, already on statin therapy, it is reasonable to continue. Over 75, it may be reasonable to initiate statin therapy after discussing potential benefits. There are hardly any risks, but benefits have to be discussed with these patients. Of course, statin should not be used in pregnancy. That's a mandatory thing that one has to remember. Now, these are recommendations of what are high dose statins and what are moderate dose statins. Now, what is a moderate dose statin? A 10 to 20 milligram of atorvastatin is called moderate dose statin. Now, I sometimes really wonder when I get patients who just had percutaneous intervention 6 months back and his doses have already been reduced to 20 milligrams of atorvastatin. This guy needs to be on 40 or 80 milligrams of statin. At least for the first year, he needs to be on 80 and then lifelong on 40. So I always change it and tell him, but then people are worried, their heart doctor may not. So I tell him, please go and show your cardiologist that you need high dose statin. And then the answer comes back, yes, you continue this 40 milligrams. So this is important to understand that you've got to really, in your mind, work out what are the risk factors that you're talking about when you're prescribing a statin dose. A statin dose is not arbitrary. It is based on the risk factors, risk stratification of a patient. What is a low dose or moderate dose statin for rosuvastatin? Only a 5 or 10. So in a person who's got a percutaneous intervention, I would never use a 10 milligram rosuvastatin, but people just like to use it with aspirin and just finish it off. Well, that's not the way to go. Just because you are finding it convenient to add it with aspirin, you continue with 10 milligrams. But this person who had a percutaneous intervention, at least for the first year, will have to have 40 milligrams. But if he has high risk factors, he will continue on 40, or maybe if he is managing other risk factors well, continue lifelong on 20. This is something very important. How well are your patients able to adhere to statin therapy? I mean, adherence is important for all therapies in chronic disease. So anybody, and this is inversely related, associated with all-cause mortality. So if your patients adhere less than 50%, then the risk of heart disease is high. If they adhere 70 to 89%, look at how the risk of mortality comes down. And this is a retrospective cohort study from the Veterans Administration health system in the US, where they really saw data of over 347,000 patients. So this very clearly shows you that if you are using statins and making sure that your patients adhere to statin, sometimes the primary physician will say, oh, aapka cholesterol is fine, just stop it. Well, this is not it. In diabetics, in people with coexisting disease, without risk factors also, statin is a lifelong therapy, as would be a metformin or other drugs for the patient. The next question that comes to your mind, probably day in and day out, are all statins equal? Well, they're not. And here's data to clearly show you. Now look at Rosuvastatin here. It stands out amongst all the statins there. Many of you may not have used simvastatin. I used simvastatin about 20 years ago when that was the only agent available. And look at the LDL cholesterol value, 28%. And look at the LDL cholesterol value lowering, 46%. So whether it is triglyceride reduction, whether it is LDL lowering, whether it is increase in HDL, I think Rosuvastatin really stands out. It is hydrophilic, has a long half-life, and renal excretion is about 30%. Bioavailability is 20%. So you can see, if you compare it with atorvastatin, LDL cholesterol lowering is 37%, and look at 46% there. Simvastatin is no more available, nobody uses it, and the others are not available here. So the drug of choice here, because of its power, really remains to be Rosuvastatin. Now, Rosuvastatin is a selective reversible HMBG-CoA reductase inhibitor. It's less lipophilic, and therefore it improves its ionic interaction with this enzyme. And this inhibition leads to decreased sterol synthesis, decreased hepatocellular cholesterol, resulting in enhanced, more LDL receptors are available, and so more LDL is taken from the circulation into the liver for clearance. The Galaxy program with Rosuvastatin. Now, what was this? Here they were trying to compare it with different doses of Rosuvastatin versus 40 versus 5, 20 versus 40, or they were trying to compare different doses of statin versus atorvastatin or simvastatin in different doses. And the aim was that statin with greatest efficacy improves atherogenic lipid profile, but also beneficially modifies inflammatory markers, which will slow the progression of atherosclerosis and improve CV outcomes. After all, we all know that inflammatory markers or inflammation is one of the most important pathogenetic mechanisms in the causation of atherosclerosis. And so these agents not only reduce LDL cholesterol, but also modify inflammatory markers and may slow progression of atherosclerosis. And so this Galaxy program, and what did this Galaxy program tell us? Is that Rosuvastatin is more effective than the comparator statins in reducing LDL, improving lipid profile, enabling patients to achieve lipid goals, more stringent goals, even in high-risk patients, but more importantly, can also probably arrest and even regress atherosclerosis. And that's what the aim of the Galaxy program was. So statins have pleiotropic effects. They not only decrease LDL cholesterol, but have anti-inflammatory effects and can regress atherosclerosis. The Uranus trial compared Rosuvastatin and atorvastatin for lipid lowering in patients with type 2 diabetes. This is specifically for type 2 diabetes. And these patients had a mean LDL of about 127 and were randomized to 10 milligram of Rosuvastatin or 10 milligram of atorvastatin. And they were trying to achieve a LDL goal of less than 116. If you see on the top panel on the right, I showed you there was a significant p-value reduction in favor of Rosuvastatin versus atorvastatin. On your right panel below are shown that almost 94% people on Rosuvastatin were able to achieve their goals as compared to only about 85 or 86% who were on atorvastatin. So Rosuvastatin was significantly more effective at reducing LDL and achieving goals in people with type 2 diabetes. Now, what happens when you need additional therapies? And these are called non-statin therapies. And ezetimibe, recently, it is a very old drug, but had lost favor, but now is back with authenticity to show that in combination with moderate or high dose statin can provide additional cardiovascular benefit in patients who have cardiac disease. The combination is better, and there is a reduction of relative reduction of almost 6.4%, an absolute reduction of almost 2.2%. The blue line shows you simvastatin plus ezetimibe, and the yellow line shows you only simvastatin. Now, when this study was seen in detail in people who were diabetics, this reduction was almost 14%. So it really benefited people who had diabetes, and this is called the Improve It trial, adding ezetimibe to statins to reduce therapy, and the combination is better. And this shows the benefit of a non-statin agent and reaffirms that the lower the better hypothesis with LDL cholesterol. Now, what do you do when you have maximally tolerated doses of statins? You've already given that. You've already given a non-statin agent, but still you're not able to achieve LDL cholesterol. Now, these are people who got either familial hypercholesterolemia or several other risk factors where their LDL just doesn't budge and it's not coming down. So you've got to use agents. And these are the most recent additions. They've been around for about a year or two in the Western world, but now evolocumab is also available in India. And these are called the PCKS9 enzymes, and these are PCKS9 inhibitors. Now, what do? They prevent the degradation of LDL receptors, and therefore they increase the hepatic clearance of LDL cholesterol and decrease LDL cholesterol in the blood. And you can see here the PKC inhibitor blocking the PCKS9 enzyme there, and thereby preventing the degradation of this enzyme goes and destroys the LDL receptor. So you have more LDL receptors, you have more LDL clearing, and you've got decrease in LDL cholesterols. And these are two important agents that are available worldwide, elirocumab and evolocumab. And evolocumab is now available in India, but unfortunately, these are all injectable therapies to be given twice a month. That's every 2 weeks, subcutaneous. But their power to reduce LDL cholesterol is tremendous, from almost 48% where rosuvastatin ends, and it goes up to 71%. Now, these are very useful in people who've got familial hypercholesterolemia, diabetics, patients with coronary artery disease, patients with renal failure. They have some adverse effects like nasopharyngitis, influenza, urinary tract infections, etc. But for people to save life, I think some people there would even require these agents. So friends, I would end my talk by getting you to the summary of the cardiovascular risk management algorithm. So as clinicians, as smart clinicians, you really need to evaluate how your patients are doing. Get the total evaluation. Look at his cardiovascular risk. Based on the risk, determine the treatment goal. Would you want your LDL to be 70? Would you want your LDL to be 50? Or would you comfortable with something like 100? Which I'm not comfortable in people with type 2 diabetes especially. Choose a treatment regimen. Use a statin or a statin plus another agent if your patients are not meeting goals on the higher dose of statins. Statins may be up-titrated for better LDL cholesterol before you add another agent. And you've got to maintain the patients at goal, and that's very important. As I mentioned, adherence is the key. In all chronic therapies, and especially when you have your aim is to reduce cardiovascular risks, to prevent cardiovascular hospitalizations, it's important to maintain people on real good statin doses. So cardiovascular risk in type 2 diabetes is heightened. I told you it's about 2 to 4%. The assessment is imperative. You've got to manage lifestyle. You've got to pay attention to hyperglycemia, hypertension, dyslipidemia, and of course, make sure your patients stop smoking. That's some very important thing, that you really need to get after patients to stop smoking. LDL-C lowering is our primary goal, and statin will be the mainstay of therapy. And the lower the LDL, the better you are. And Rosuvastatin is probably the most powerful statin and has been extensively used in people with type 2 diabetes with significant benefits. Thank you very much for your attention. So I can see some questions here. So patient is a diabetic having triglyceride 450 and LDL is 100. What treatment should he receive? Well, the rule is anybody who's got triglyceride less than 500, all have to be on high dose statin. Now, when you've got a 450 triglyceride, always get his glycemia under control. Make sure the patient has a good diet which is free of saturated fats, trans fats, his blood sugars are under control. As soon as you get his blood sugar under control, his triglycerides are going to fall. You do nothing, his triglycerides are going to fall. But this patient needs to be on statin therapy. I showed you that statins can reduce both LDL, can reduce triglycerides, and also increase HDL cholesterol. So these patients will have to be on statins in addition to managing his lifestyle and getting his diet and other things in control, especially blood sugars.
So if you'll scroll down in chat box, then you can see the more question.
Okay. Yeah. Which statin is better for diabetes? Etoba, Rosuvastatin. I've shown you the data. Rosuvastatin, of course, is the key because of its power to reduce LDL, to reduce triglycerides. And so I would use a Rosuvastatin for no other reason except that it is very powerful and it will help you achieve your LDL goal without any issue. At what level of triglyceride one should use a fenofibrate combination? I would never use a fenofibrate combination with statin. You know, the most important thing is if your triglyceride is over 500 or 700 or 1000, it's important to manage other things which increase triglycerides, like make him stop alcohol, get his blood sugar under control, put him, if he's over 500 or 1000, you've got to prevent pancreatitis. So here are patients who will need fenofibrate. I never combine the two because then the patient continues to have it for the rest of his life. He doesn't come back. So combining fenofibrate is not a good idea. Here in such patients, you could prescribe a fenofibrate and say, take it for 2 months, but then the patient has to return to LDL lowering. His answer would be on statins. As simple as that. Which antiplatelets? Aspirin, clopidogrel? Well, these are agents that your cardiologist will decide because of the nature of cardiovascular disease. And I think aspirin is a must, but people who can't tolerate aspirin for some reason, clopidogrel along with statin will be used. But of course, aspirin will have to be there. If he's had a percutaneous intervention, I think both aspirin and clopidogrel will have to be there for at least 1 year, and then you can take away the clopidogrel, but aspirin will always be there. I think somebody's asked, should all diabetic patients be given statins regardless of lipid status? I think I've made it amply clear that without any reason, you've got to believe that all people have to be on statin regardless of lipid status. Now, let me just give you an example. Somebody who's 30 years of age. He has no other risk factor, type 2 diabetes. I would not put him on a statin. But as soon as he's coming near that age of 40, he's got hypertension, or if he was 30 and he was a smoker, he would be on statin. So you've got to really work out those risk stratification. Somebody's got type 1 diabetes for 10 years. He's now 25. I would put him on statin. He's already got a risk there. So you've got to really work out the risk of the patient. But ideally, I would say all diabetics need to be on statins. What is the ideal value of LDL and triglyceride for diabetic patients? Well, all triglyceride has to be less than 150. And LDL cholesterol goals will have to be decided according to the patient's profile. I always like to keep the LDL cholesterol, irrespective of what he is, what his other data is, to less than 70. Asian Indians, he's a type 2 diabetic, and God knows when he comes back to you. So keep it under 70, and you send less people to the hospital for events. Are diabetics on high risk of COVID infections? Well, the answer here is that because you are a diabetic, you are not at high risk of COVID infection. But because you are a diabetic, if you're not uncontrolled, then your outcomes are poor if you are not managed well. So I advise all people whom I see on video consultations these days, control your blood sugars extremely well, keep yourself in tight control, because if you don't do that, and God forbid you got a COVID infection, your outcome is not going to be good. So I got a thank you from somebody there. Thank you very much. I think we are done with all the questions there.
Yeah, right, sir. That was the last question from Dr. R.C. Saini.
Thank you. Thank you very much.
So, sir, with your permission, shall we conclude the session?
I think so. You can ask the organizers. I'm fine with it. If there are no questions, we can conclude.
One more thank you received.
Okay. Thank you. Thank you very much. So we can close it?
Yes, sir.
Okay.
So, thank you, sir. Thank you on behalf of Lupin for your insightful and educative talk. Thank you. I'm ending the session.
Thank you.